Hi, good afternoon, everybody. Can you see my screen?
Yes, we can. Please go ahead.
Thank you. So I think after Darius' Eureka moment, I hope we are able to find some Eureka moments in morbid PDR as well. Uh, so as far as PDR goes, I think PDR is actually a proliferative vascular vitreoretinopathy. Now, what differentiates it from simple PVR is the vascular connections or the vascular nails, which are basically connections between the retina and the fibrovascular tissue. Along with that is the hemorrhage, which could be either vitreous hemorrhage or even intraretinal, and even the hemorrhage between the vitreous and the retina. Now, the most important part which needs to be recognized in a case of PDR or surgical PDR is vitreoschisis. Now, this is almost always present in cases of PDR which require a surgery. These are the various forms that you could basically see in a morbid case where you could have a focal, all over elevated hyaloid with fibrovascular tissue, or you could have this typical C pattern, which is extensively fibrous. Then there are cases where the macular part is very good, but you have these anterior, vitreous proliferations which are present. So now the most important part, as I said, was vitreoschisis. Now, why is it so important to recognize it? Now, it is very important to recognize vitreoschisis because being in the correct plane is extremely crucial to the success of membrane dissection. And knowledge of vitreoschisis and the ability to identify it preoperatively and intraoperatively is extremely critical in finding that correct plane of dissection. Preoperatively, we usually use Swepsos OCT to study our cases, whereas intraoperatively, someone could use triamcinolone or the dual dyes. Being in a correct plane makes a difficult case simple, whereas being in the incorrect plane could land you up with iatrogenic breaks and bleeding, which could make the case extremely messy. So I like to just demonstrate vitreoschisis through this animation. So as we all know that in a case of PDR, we have these elevated prolifs, neovascular prolifs, which kind of grow into the vitreous cortex, and then they kind of grow tangentially into a space, and rather creating a space which divides the vitreous into two leaves, the anterior vitreous leaf and the posterior vitreous leaf. And it is very important and critical to kind of, when we see the retina, what we are actually visualizing is the anterior vitreous leaf and not the posterior vitreous leaf. So it's important to kind of acknowledge this fact that, most of the times you would find a vitreoschisis in the case of PDR, and it is essential that we find the right plane or the right plane of entry so as to have a complete membrane dissection possible. I think Swepsos OCT, which we commonly use to study these cases, I think in this scan also you can see that very clearly see a split within the posterior cortical vitreous, which is visualized as two distinct hyperreflective bands. So the band which is marked with the green arrow is the anterior vitreous leaf, and the vitreoschisis leaf, and the band which is marked with the blue arrows is the posterior vitreous leaf. And it is very critical that we go under this band, under the blue band, right? So we also study our cases. Again, I think I would suggest studying these cases on a Swepsos OCT if possible, through various cuts and various planes, and kind of visualize, kind of mentally make a picture of the case as to how you would like to enter and which would be the best plane to enter. I think this has also been very well described by Stanga et al., where they have described various morphological and pathoanatomical features of cases of PDR with a Swepsos machine. However, obviously, Swepsos preoperative testing is kind of limited to patients with no or minimal vitreous hemorrhage, whereas intraoperative OCT is again a tool which is can be helpful in these cases after removing the vitreous hemorrhage. Whenever we talk about diabetic vitrectomy, I think the following factors do play an important role, which is preoperative anti-VEGF, combining it with the phacoemulsification, infusion pressure, bimanual dissection, and definitely maintaining hemostasis during these tough cases. And I think the tamponade and a very good laser is something very important. Now, preoperative anti-VEGF, I think, is something which we feel is definitely essential. I think there is always a debate whether a more fibrous membrane would ultimately make it difficult to find the plane. But I think with experience and time and patience, I think finding the plane becomes easier, whereas handling very hemorrhagic retina, kind of tackling a bad hemorrhage at that time becomes way more difficult. Combining with phacoevitrectomies, I feel in any case of PDR, I'm not a very great proponent of limited vitrectomies. I think it should be a complete vitrectomy. I think all sort of fibrovascular polyps should be removed and well cauterized. So I think it makes the surgeries, makes the surgeon very not defensive. The person is not at all defensive, and you get a very good view, and I think can do a complete vitrectomy. Bimanual surgery, definitely, because you get excellent control. I think Dr. Reyes has already shown bimanual surgeries uh, in cases of recurrent detachment. I think the same role also goes here. And I think especially in PDR, I think lifting the membrane with one hand and cleaving your way through the plane with the other hand, I think is very essential. Also, one technique of coagulation of bleeders, which I'll be showing later can be done with a bimanual technique. So this is so basically mostly in cases of normal PDR vitrectomy, you would find this plane of dissection somewhere in the mid periphery or at the posterior pole. So as we see in this case, there's extensive fibrovascular membranes which are present. Now we do enter into a plane, but if you see this sheen which is coming here, where marked by the yellow arrow, this basically tells us that probably we are not in the right plane. So this sheen is also a very important clinical indicator or surgical indicator that I look at. And then you go back and grasp again, and there you find that you finally entered into the right plane. And after you're into the right plane, I think it's just a matter of time, and without any more any iatrogenic breaks or extensive bleeding, you can probably finish your case. So what makes the surgeries, what makes PDR more morbid? It is definitely the extensive fibrovascular proliferation. I think very tight, adherent posterior hyaloid. I think personally what I feel is sometimes you'll look at a case and look very simple, but then this very, very adherent hyaloid, especially in a retina which is, attached, and prognosis is good. I think adherent hyaloid is extremely tough. And again, the role of vitroschisis, knowledge of vitroschisis is very important here. Again, then dense clotted heme also makes it extremely morbid. And dense vitreous hemorrhage, definitely when you don't know what is there behind, obviously the situation is morbid. And to top it all, I think a detached retina adds to the confusion. So I think with morbid PDR, where preoperative assessment is not possible, then I think there are no definite rules as such, but then I think you should go by instinct, follow the rules that have been taught over the years, and slowly and gently kind of cleave your plane through. So if we see this case, I think there's extensively dense vitreous hemorrhage. There's nothing that you can see. There's a kind of a heterogeneous kind of a glow. I think you go layer by layer, keep your cutter up. I think the cutting edge should be up, and kind of go layer by layer and clear the vitreous hemorrhage. After that, I think important to start bimanual dissection and try to find your plane through. I feel that you should kind of probably study the crust and the troughs and kind of align your scissors in that way. And I think the best tip would be to kind of follow the topography of the membrane that you see, or the next step that you see. I mean, there are obviously high chances that you might end up with an iatrogenic break, but then it's okay in situations like this. I think you need to keep your morale high and tackle your way through. And ultimately, even when these cases feel that they are never ending, I think there are times when you can successfully kind of complete these cases without much trauma. There are other situations which make the case morbid. Those are those anterior extensions of fibrovascular polyps, then coexistent macular hole or RD with PVR. And so in this case, we see that so this person basically has a fibrovascular polyp along with the associated macular hole. And so as routinely, we kind of dissect our membrane bimanually. And now very important is that when you start the ILM peel, we would prefer doing the with the forceps. I think Tano does not work too well because I think the macular edema is there and it's very boggy. And I think it's important that you go from outside in and not go from inside out, because there's a huge tendency that you might just kind of make the hole more larger than smaller. And so I think gently kind of remove the ILM, and the force should be tough enough, but quite slow. This was one more thing that I wanted to show, which was basically a bimanual endodiathermy. I think this helps because it helps us in not increasing the bottle height too frequently. So basically you can hold a backflush needle in one hand and relieve the hemorrhage, and you can very clearly pinpoint the bleeder and then cauterize it. So this is one more case of anterior prolif. I wanted to show this case because I think in this age, I don't know how many of us are really using these contact lenses, but I think a contact lens really helps, especially the prism lens in these mid-peripheral areas, and you get a very good view, and I think it makes the surgery much more easier and much more comfortable, and you can completely remove these prolifs very well. This is one more case which has been done. I think we did it just a few days back. And this case, I think, tops it all. I think it has a combined detachment. And before I start the video, it had a combined detachment. It had this very bad prolif which was pulling up the macula. And there was actually one attachment which was directly at the fovea. I think the detachment was extending probably, I think the inferonasal to, I think the 12 to 8 was the only area which the retina was attached, and there was a break in both the quadrants in that area. So it was extremely difficult for me to, for us to kind of go, or, complete the PVD. I mean, enter the hyaloid from the nasal side. So in this case, I think we thought a little different, and usually we like to go from outside in, but in this case, because the hyaloid separation at the base was not possible, so we debulked the hyaloid and then started going in from the inside out. So after finding a cleavage plane over here, we kind of were able to kind of remove the membrane, and I think very gently and with a lot of patience, I think we were able to remove the complete membrane. And then this dissection was happening over a pre-existing break which was there. I think it's important to kind of change your ways at time, because in this case, if I would have ended up with a very bullous retina, I think it would have made things extremely messy. So then slowly we kind of remove this membrane, and then we extend the hyaloid till the base and complete the base excision also. One more tip is that I think if you're not able to find a plain surgical plane in the periphery at the first go, I think it's important that you debulk the base at least before you start membrane dissection, and then you can have an attached retina. So just to summarize, I think adhere to the surgical principles. I think however simple or tough a case appears, I think always be prepared to adapt in these tough situations and alter plan according to the need on the spot. And I think perseverance always definitely plays a very important role. Thank you.